is going to be kicking us off on presenting on the fetal therapy domain, and we plan to have these kinds of presentations on the various areas of focus in the Dunlevie Center on a regular basis, with different presenters, and I think just to keep all of us aware of the activity that's going on as this program develops, as the center develops. There has been a lot of activity happening with a great team working behind the scenes around the Dunlevie program. And just to summarize a few of the things that that we have done so far. 2 national searches have been launched in perinatal epidemiology and in basic science, with Virginia chairing the basic science search. The space for the Dunlevie Center has been identified. Page Mill Road, a generous space in the old Theranos building for the population health domain, as well as a potential lab space in that same building. An endowed professorship has been awarded, as you know, to Dr. Deirdre Lyle. We're launching these monthly research presentations, of which this is the first. A fetal therapy symposium is planned for October or November under the Dunlevie Center. Dunlevie Center has funding is supporting 2 important collaborations. One is a unique OSHPD-linked maternal child data set that Susan Carmichael and Henry Lee are maintaining, and which will give all of us access to that unique data set, as well as support for Anushka's Chouakeski, I think I sorry if I mispronounced her name, basic and translational investigation into fetal therapy for the disease Fanconi anemia. We also have hired a grant writer to support the Dunlevie Center. We've met with multiple scientific leaders and potential collaborators across Stanford with great enthusiasm from the community. We are developing a seed grant infrastructure in consultation with MCHRI and the Stanford Cancer Center and others. We are launching a website that Janina and Anna have just emailed me some templates on that looks awesome. We are continuing with weekly administrative meetings to review progress. Center executive leadership plans are currently being finalized, and the center financial and administrative structure is near final. So a lot of work, a lot of great forward momentum, and I will shut up now and let Yair talk.
Okay. Wow. Thanks, Yasser. That's I think really hard to follow all that amazing work that's happening so quickly in so many domains. It's really fun and exciting to be a part of a small part of that, or at least the part that I'm really involved with. But so much excitement and so many great aspects to this. Such an amazing program, and thanks for shepherding that, Yasser. Let me share my screen here a bit. 1 second. All right. So, in a time limit amount of like 40 minutes, usually it would be enough for maybe one disorder, and we can delve sort of deeply into that. But given the heterogeneous group that we have logged in today, and given that this is the first one, I thought about just giving you guys an overview, especially for people who might not be intertwined in our fetal center and the fetal therapy program, just to give you an idea of what we're doing. This might seem like you're inundated with a lot of maybe sort of information, but hopefully you'll get a flavor of what we're doing. Even though I'm presenting, there are a lot of individuals involved in the fetal program, and I saw that Susan is on, and I have to tip my hat and recognize Susan for being the medical, sort of leader and all around leader of the fetal program, of which the fetal therapy program is a part of, but only a small section of that. And I did borrow and will recognize Susan's slides at the beginning. So Feel free to stop me at any point. This is meant to be informal, and I'm happy to answer any questions either in the time that we have left or in the, via chat or whatnot. All right. So, this is sort of a picture from many, many years ago. And I think if we had to take the same picture now of everybody that's involved in the fetal program, it would probably be 2 to 3 times the size. But the point is, it's very, very multidisciplinary. This is not a one-person show or a 2-person show. There are a lot of individuals, both on the medical side, the administrative side, the financial side, to make a program like this work. When you look at the referrals that we have, these are from Dr. Hintz again. Thank you, Susan. The referrals that we get for the fetal program are very diverse, and they come from all over the country, and we get international referrals as well. And at any given time, the program and all of us in the MFM division, who of course are a part of the program, we perform surveillance for approximately 100 to 120 ongoing pregnancies. So these are people that we see in our clinics in collaboration with Dr. Hintz and her colleagues and the pediatric subspecialists. And we get them sort of into the program prior to their delivery and coordinate their care in that way. And so really it's a continuum from prenatal to intrapartum, and then of course, long-term within the Packard umbrella. But of course, what we're going to be talking about today is really sort of quaternary care and the very specialized fetal anomalies, some of which are amenable to fetal therapy. And that's where sort of some of us who are involved with that come in. When we think about fetal therapy, there are certain guiding principles. So these are obviously invasive procedures. And so anytime we have to go through a healthy mommy to get to an ill fetus, we take that very seriously. And we would only want to do that if the anomaly is really severe, potentially life-threatening, because the last thing we want to do is risk mom's health to try to treat the fetus. In an ideal world, the anomaly would be isolated. This is sort of a moving target, especially as we learn more about genetics and the associated genetic syndromes. But generally, in an ideal world, the anomaly is isolated so that the therapy can really make a difference in the trajectory of the disease. Ideally, there would be sufficient animal or human data to suggest a benefit. And if something is investigational, it must be treated in that way, including IRB and Data Safety Monitoring Board. Risk to the mother this is probably the most paramount bullet point on this slide. I cannot emphasize this enough. And the risks, some of them are known, and sometimes they're actually unknown when we have research studies. And of course, the mother and the family need to be well informed. I could tell you in general, both myself, I have to admit, and other fetal therapy sort of specialists around the country, we tend to be very overzealous. We tend to be excited about the interventions, and that can bias the way we counsel patients. And so I must confess that here I am kept well in check, both by my pediatric colleagues and others, as well as by our social workers and coordinators, and everybody has a voice at the table. Not once they've said, look, this is not an appropriate candidate. And I respect everybody's opinion, and we look at the patient and the family as a whole. So it's very, very important that these families are very informed and counseled in a non-biased way. And again, we must have IRB approvals and other oversight for experimental protocols. And I think we do that. From a maternal standpoint, we must know all the comorbidities, either that will affect the technical aspects of the intervention or the theoretical risks of prematurity and other complications. The gestational age needs to make sense, meaning are we intervening at a gestational age where we can make a difference? There's no point in performing an invasive procedure if mom will deliver in about a week. And of course, the Achilles heel really of preterm or of prenatal therapy is really preterm birth, and we're starting to look at some of the risk factors related to that. So here's an example of a case that we had not too long ago where we were trying to assess the cervix to make sure that mom's not at risk for preterm birth. Here is the head of the baby. This is endovaginal ultrasound. This is the cervix, and it didn't quite look like a cervix. And we advanced the probe a little bit more, and all of a sudden we thought the cervix was maybe a little bit short. And eventually the cervix was actually quite dilated, and this is almost neurosonography here. And we obviously did not perform in utero therapy for this case, and mom actually ended up delivering within a day. When we think about fetal therapy, we have to divide the group into two types of therapies. One is medical therapy, which is as important as surgical therapy, sometimes even more so. And these things include treatment of fetal arrhythmias, other sort of preventative interventions, and treatment of viral infections. And many of these disorders, there's a lot of research coming up in that. We work with Natalie Aziz, for example, on appropriate therapy for CMV. We work with our pediatric cardiologists and the electrophysiology specialists to treat fetal arrhythmias. And under this medical therapy, Yair alluded to this, but I did want to highlight the fact that we're starting to look at least in translational models, in utero medical therapy for fetal and neonatal congenital genetic diseases. And Yair mentioned the Fanconi anemia model, and we're looking at others. And that will become, I think, in future presentations, we'll take up, hopefully, this part of the slide. We have to think about whether the surgical therapies that we perform, whether those are definitive therapies or temporizing therapies. And you can see there are very few definitive therapies surgically that we offer patients. The vast majority of time that we perform interventional therapies, it's really a temporizing measure to either prevent or treat high drops, to try to get advanced gestational age, to give the baby a fighting chance. And only in maybe spina bifida and twins do we actually perform a definitive therapy where it's a one and done. And all the other ones are really diverting procedures and other things that I'll go into in a second. We're certainly starting to see more complex twins being referred, and the classic disorder for complex monochorionic twins is something called twin transfusion syndrome, which happens in approximately 10 to 15% of all monochorionic twins. These are twins that were formed by a single egg and a single sperm, so they're monozygotic. And in terms of monodi twins, that embryo split at 4 to 8 days gestational age. It's very important that we determine chorionicity in the first trimester. This is an example of the sonographic signs of monochorionic twinning in the first trimester. We have a single placenta and a very thin membrane, and this is a monochorionic diamniotic twin. This is important because as the gestation progresses, it's not just about twin transfusion syndrome, but also other complications that we look for, including selective fetal growth restriction. Selective fetal growth restriction is a condition where one fetus doesn't grow as well as the other fetus, usually because of an imbalance on the placental, meaning one baby has a higher share of the placental segment than another. And we actually have very strict protocols on the surveillance of monochorionic twins. Everything is standardized across the entire enterprise so that women who are coming for prenatal surveillance and care in our satellite offices, be it in Modesto or Salinas, get the same care that women who are coming to the main ultrasound unit. And we do not separate the care based on insurance status or sociodemographic information or whatever. Everybody gets the highest level of care possible. This is an example of fetal growth restriction in the second trimester, where we had normal Doppler in one baby. And here, when you're looking at the umbilical artery Doppler, you can start to see reverse flow. Even this was a very significant fetal growth restriction. And actually, a couple of days later, unfortunately, the baby passed away. And what happens is, as soon as one fetus passes away, it becomes a sink. And because of shared connections along the placental surface, immediately blood goes from the surviving twin into the demised twin, and that can lead to immediate adverse neurological injury or demise in the surviving twin. And this is an example where we perform middle cerebral artery Doppler, where we're looking for fetal anemia in the surviving twin, and here it was already elevated the next day. And this can lead to either demise or significant neurological injury. So we're very, very careful, and we counsel a lot of twins nowadays where they present not just with twin, but with one fetus not growing well. And the question is, what can we do about it? Well, if we have a condition where one fetus doesn't grow well and it seems to be quite ill, one of the therapies that we offer is actually radiofrequency ablation, where we say, look, this fetus unfortunately has no chance of survival, and we're very concerned that we're at a stage where we have imminent demise. And so we perform a controlled feticide where we insert a radiofrequency catheter into the umbilical cord insertion site of the growth restricted twin, and we, in a controlled fashion, stop the blood flow to that twin in order to avoid the demise of that baby in a way that it becomes a sink and you have anemia in the co-twin. And this is an example of some of the data for RFA, and you can see in this cohort from Israel in selective IUGR cases, again, not many, the likelihood of taking home a healthy co-twin was still not 100%, meaning in 10 to 15% of cases when you do RFA, there's risk of complications, including rupture of membranes and prematurity and demise of the other twin. So still not a perfect therapy, but in cases where we think demise is imminent, we want to at least offer this to our patients, and we do. Back to twin-twin transfusion syndrome. This is a schematic of that process. Again, you have a single placenta. You have these connections along the placental surface and the dividing membrane. And twin-twin transfusion syndrome has nothing to do with the size of the baby. You can have perfectly grown twins, but with very severe twin-twin. It's all about the plumbing and the shared circulation between the twins. And we have this sort of staging system for TTTS where we follow these twins. Stage 1 is a situation where we have increased fluid in the recipient twin and decreased fluid in the donor twin. This is because as this donor twin pumps more blood into the recipient twin needs to get rid of fluid, and it does that by urinating extra volume. And in the donor twin, because more blood is going to the recipient, it shunts blood away from the kidneys and towards more vital organs like the brain and the heart. And so over time, there's decreased urine production. Eventually, there's so little urine production that the bladder is no longer visible. With stage 3, we start to see Doppler abnormalities, cardiovascular abnormalities, predominantly in the recipient twin. Stage 4 is fetal heart failure, essentially either in the donor or recipient, and stage 5 is death. And this is what it looks like on ultrasound. You have polyhydramnios in the recipient, oligohydramnios in the donor. And if we perform fetoscopy, where we try to perform therapy, this is what a donor twin looks like. And you can see here's a limb. These are the membranes completely saran wrapped around this limb. And that's sort of the images that we're able to get. Left untreated, the demise of both twins is up to 90% of cases, either because the polyhydramnios eventually leads to cervical incompetence and preterm labor, or because of progression of TTTS, where we start to get hydrops and death, and a lot of other complications, including rupture of membranes and other things. And so the therapy for at least stage 2 TTTS, and now maybe even stage 1, is fetoscopic laser. It's a procedure that we do in our operating rooms under controlled conditions. We have phenomenal obstetric anesthesia colleagues. I saw that Brandon's on the line. We couldn't do this without them. This is done under almost conscious sedation, not general. And we make a small incision, insert a trocar, and through that, there's a scope, and you can see the laser fiber, and we look for these shared anastomoses. And I know many people on the call have joined us in these surgeries. Again, this is not a one-person job. It takes a team, and I think we have a really, really good team in place to perform these kind of therapies where we look at the connections over here like that, and we ablate them. And of course, we're able to get some nice images of the babies, but that's not the point of laser therapy. When we perform these, we hope that we get all the connections, but we still keep a close eye on the twins because we can have some postoperative complications, not just obstetric complications like premature rupture of the membranes and preterm labor, but sometimes we miss vessels or the whole physiology sort of changes. And one of the complications is called TAPS, or twin anemia polycythemia sequence, where a small vessel is missed and almost the physiology reverses, and we get anemia in one twin and polycythemia in the next. And so after these lasers, we keep a close eye on them and perform ongoing assessments of the middle cerebral artery to look for that. And to try to prevent that, not only do we ablate the connections, but we perform this sort of Solomonization line based on the story of King Solomon dividing the twins in order to prevent post-laser TAPS or reduce that risk. This is an example of one of the algorithms that we have for routine monochorionic twin surveillance. We have another sort of paradigm, and our PDCs, our ultrasound units, are simply outstanding. I cannot say enough. And it's led by our lead sonographer, Barb, who's honestly keeps us in check, and we have ongoing QA processes that are performed quarterly, and we have sort of these meetings where we are then told what we missed, what we got right, and we've published on the QA process, and it's recognized now around the country and the world. We're very interested in fetal lung lesions. We have an IRB approved data set where we have ongoing clinical outcomes research studies on this. Again, we couldn't do this without our neonatology colleagues, and shout out to our pediatric surgeons and pediatric radiologists who are an integral part of our fetal lung program. There are different kinds of lung masses. They're not always the same. The names keep changing, and the evaluation just keeps getting better and better. And we've done a fair amount of research, and you can find these. I'm happy to share manuscripts that have come out of Packard related to that, but we can perform very advanced ultrasound, both in 2D and 3D, to try to figure out the type of underlying lung lesion. These could be solid or multicystic with a variety of etiologies, with or without feeding vessels. And this is an example of a large space occupying lesion that you can see here. This one happens to have a macrocyst, and you can see the bottom picture below. This is the heart completely pushed over with a lung lesion that's happens to be solid. So they come in all sorts of shapes and sizes. We spent a lot of time in multidisciplinary meetings, going over the lesions, coming up with plans for management, and determining whether therapy in select group of cases is appropriate. This is an example. I think Dr. Chue performed an in utero shunt to save this child. It was publicized at the LPCH newsletter. And these are the kind of shunts that we can perform whenever there's a large cyst. This is called the Harrison shunt, after Mike Harrison at UCSF. It's a smaller, more malleable shunt, and this is called a rocket shunt, based on a company at the UK called Rocket or Rodec, who invented the shunt. And there are two types of shunts that we use. This is an example of draining a cyst right before delivery to optimize delivery, and you can see right before delivery we drain the cyst, and all of a sudden the heart pops into view right before the planned C-section. A rare but significant fetal anomaly that we're interested in on the fetal side is called Ludo, which is lower urinary tract obstruction. This is not a distinct malformation, but a group of malformations that lead to the same findings. A little bit of embryology. The kidneys develop very early on in gestation, and very small abnormalities can lead to very significant issues, and usually, or sometimes even lethal issues. We see a lot of renal abnormalities beyond Ludo. We use ultrasound and MRI, and we partner with our pediatric nephrologists and urologists to manage these complex pregnancies. So in addition to Ludo, we have cystic renal disease and other obstructive uropathies, and we've actually published extensively, or excuse me, partnered extensively with our prenatal genetics colleagues, and actually published on these, looking at genetic issues related to renal anomalies as well. So really multidisciplinary in nature. Regarding Ludo and other complex renal issues, these could be life-threatening for two reasons. One is because of the kidney issues, but more importantly, if the kidneys are not functioning well and there's decreased urine output, then that really impedes lung development. And if you look at the schematic, not to sort of go into the weeds, but there's a significant amount of lung development that happens starting at 16 to 24 weeks and then all the way to term. And if anywhere in that process, the fluid level decreases significantly, you can have significant effects on pulmonary development. And many of these children pass away not because of the renal issues, but because of respiratory insufficiency. And so the question is, can we do something prenatally to change this sort of trajectory? And so with Ludo, which is obviously not a subtle defect, this is an example of a first trimester case. You can see a very, very dilated bladder. You can even in the first trimester start to see these dilated kidneys. This is a cartoon of what this looks like. There's an obstruction in the urethra. Fluid starts to build up and starts putting pressure on the kidneys. And we can see these in the first trimester. You'll notice that in the first trimester, we still have amniotic fluid, because in the first trimester, the amniotic fluid around the fetus is actually not made by the fetus itself, but that happens at about 16 to 20 weeks. By 16 to 20 weeks, we start to see abnormalities there. Ludo is a finding, not a diagnosis. There are a lot of etiologies that lead to this obstruction, the most common of which is posterior urethral valves, but it could also be urethral atresia, stenosis, prune belly syndrome, and one syndrome that's missing that we see a fair amount of actually is cloacal abnormalities and other genetic syndromes.
Yair?
Yes.
I think Dr. Gibbs had a question.
Sure. Of the referrals, roughly how many were for maternal fetal infections? CMV, we would have to ask Natalie this. In terms of the therapy, I know she's seeing a lot more CMV, but I'd defer to her, and I know we keep track of these. I can get you those numbers later on. I hope you meant CMV and not just other infections, Ron.
Well, I was interested in the whole spread, and with the resources here, I wonder whether this might provide an opportunity for a national referral center.
Yes, and I know that Natalie and Yasser were involved in the MFM UCMV study. And so I think the center is well recognized. At least, again, I keep harping on CMV because that's the classic infection that there's a lot of activity about therapy. But your point is well taken. And again, having Natalie is clearly an asset, and she's an important part of the fetal program.
Yeah,
I could just add, just a couple of things. Ron, we see a lot of referrals for potential infections, findings like calcifications, early IUGR, other things. So we get that panoply of referrals under that kind of broad umbrella of risk of fetal infection. We used to be, and I'm not quite sure whether we still are, the main site out of PAMF actually was the lab, Remington's lab for toxoplasmosis. I'm not sure what the current status. I still believe that lab is operational, but I'm not entirely sure. So between kind of our national activity in the CMV trial, which you were part of as well, Ron, and the broad net of referrals we get, but I can't say that we're seeing a lot of positives, right? So we get a lot of presumed, but most are negative.
Yeah. I think the common chief complaint would be, is this fetal anomaly an infection, or is this maternal symptomatology an infection likely to cause fetal abnormalities? And anyway, we might follow that up in a discussion later.
Yeah, thanks. Just one last point about that. When you look at certain fetal therapy centers, I would say predominantly around the world, I'll give you an example of Paris, where Yves Villers, he's a world-renowned fetal therapy expert in a huge center. CMV is as important as TTTS. So your point is well recognized, and getting it under the fetal therapy program is important, and I think we're doing that. For Ludo, sorry to jump back, these are again the shunts that we use. Again, these are invasive procedures that we take very seriously. We perform these in operating rooms, usually on labor and delivery. And this is an example of the second trimester Ludo. Again, by this time, you can see there's no amniotic fluid. The bladder is quite distended. The kidneys are enlarged and hydronephrotic. And the therapy is under ultrasound guidance. We insert these trocars, and we, under ultrasound guidance, you can see the part that goes into the bladder. The distal end is injected into this, and eventually the proximal end goes into the fluid cavity. You actually have to insert fluid, and this is what it looks like afterwards, with the bladder very sort of thickened and abnormal, but you can see that now there's fluid around the baby. The issue with these is that these are not one and done procedures. They can be dislodged or get dislodged over time, and we counsel patients appropriately about that. When the shunt goes in, we can still see that the damage to the kidneys is not gone. And so when we counsel patients prior to these procedures, along with our neonatology and nephrology and urology colleagues, we clearly counsel them that, that they have to be willing to accept some degree of renal insufficiency. But the point is to pick the most severe cases that are at risk for demise so that we can change the trajectory of that particular outcome. Shunting has significant complications. Predominantly because they're not perfect. They migrate, they clog, we need to do multiple procedures. And so one of the things that people have looked at is whether one can perform cystoscopy and actually ablate valves, but these procedures are quite risky. And once you start finding lasers inside a small space, you can end up with fistulas and other complications. So the technology is not quite there for that. And people have performed these MRI studies, and they've shown that we need better instruments. One of the things that we probably should be looking at Packard or Stanford, given everybody's experience and expertise, is fetal therapy instrumentation to see if we can improve that particular disorder. In the meantime, what we have done is partnered with Biodesign and Urology to try to see if we can create a novel shunt. And this is an example of a new bladder shunt fetal bladder shunt that we've designed. It's still in the prototype phase. And instead of having sort of a pigtail catheter, we have these two sort of ends that are more fixed, almost like a ASD device in adults. And there's a little duckbill valve that'll go in here to help with bladder cycling. And we've performed sort of benchtop pig bladder studies for the time being. And we've shown that with pull-out force mechanism trials, these are a lot more difficult to dislodge. They're very, very echogenic by ultrasound. And we think this is a pretty good, this is our prototype in a benchtop model. And you can see this is actually a pig bladder that we've fixed. And you can see under ultrasound, you actually get sort of the same fidelity and sort of the visualization, and you can see this fluid draining, and we've received a Spectrum grant for this, and we're hoping to try this in large animal models. And I'm happy to talk more about that offline. Consistent with urological and GU abnormalities, we're very interested now in a disease called bilateral renal agenesis, which is a disease that people have known about for a long time. This is a universally lethal disorder up until about 7 years ago, when a group from Johns Hopkins described serial amnioinfusion where the child survived. Again, when you have bilateral renal agenesis and no amniotic fluid is being produced, essentially there's anhydramnios, or no fluid, starting very early on in gestation at approximately 18 to 20 weeks. This group from Johns Hopkins was able to perform serial amnioinfusions at least weekly, at least to improve lung growth. The child was delivered, survived, and actually was transferred over to LPCH at several months of life, and was cared for in our NICU with our pediatric nephrologists and urologists. This ended up being a prominent or well-recognized family and made a lot of headways, and sort of launched the modern, I would say, focus on serial amnioinfusion as a therapy. The problem was, a couple of years after this case report, it seemed like a lot of people were performing serial amnioinfusions, but it was unclear what the benefit was, how many children made it or didn't make it, what the harm to women was. And clearly this was highly investigational, and a group convened at Johns Hopkins, including with our pediatric nephrologist, Paul Grimm. And essentially the group decided that this should only be done under an IRB umbrella with clinical and DSMB oversight, and that it was unethical really to perform this as an ad hoc fashion. And they recommended that a trial be instituted. And essentially this led to the RAF trial, which I'll go through in a minute. But just to show you the procedure, this is under ultrasound guidance. We inject a needle into a confined space near a limb, and then fluid is gently inserted to create a pocket. And eventually we insert, sort of artificial fluid. The fetus will swallow this fluid over time. And so these need to be performed at least weekly. And you can imagine, even though it's a needle-based procedure, every time we do this, there's a risk of infection and trauma to the membranes and risk for prematurity. There's a lot of information that we don't know. What is the optimal time to start these amnioinfusions? What's the optimal frequency? What's the fetal benefit or risk or harm? And this really launched the NICHD-sponsored RAF trial that we're a part of, where women with bilateral renal agenesis or other renal diseases are offered this study. The primary outcome is not how many children will survive to transplant or long-term, although that is the data that everyone is interested in, but really, do serial amnioinfusions help promote lung growth so that at least we can overcome the initial lethal sort of period, which is the first 24, 48 hours. I must say that our pediatric neonatologists predominantly and our nephrologists are learning a lot from this trial. They're dealing with a lot of comorbidities in the neonatal period, and they're doing an amazing job, and they're partnering with their colleagues around the country from the centers that are involved with this. And there's a lot of information that is gained, and the study is ongoing. This is a highly, highly, highly experimental study with a very strict inclusion and exclusion criteria. We're a part of 7 to 8 centers that are part of the trial, and we've received referrals literally from all over the world who are interested in participating. And I think we have a really, really great multidisciplinary program that allows the enrollment and safe application or offering of this study. Exit procedures are these procedures that are meant to help improve the immediate respiratory support of neonates or fetuses complicated by airway malformations. This includes a myriad of conditions, including large masses in the neck that you can see here, or significant retrognathia or micrognathia, where the lower chin essentially is retracted backwards, inhibiting the trachea. We spend a lot of time in a multidisciplinary fashion reviewing ultrasounds and MRIs to determine who's a candidate for these exit procedures. And essentially, these are done in the LPCH main operating room. And what happens is we perform a C-section under general anesthesia with our support of our OB anesthesiologist. Essentially, half the baby is delivered. The other half stays attached to the placenta. And in this case, you can see our ENT colleagues, half the baby is still inside, receiving oxygen through the placenta so that a tracheostomy can be performed over the course of about 15 to 20 minutes. The airway secured, and then we deliver the baby. You can see this particular baby has significant retrognathia. And again, a very multidisciplinary team, 5 to 6 different services in the OR, including us, neonatology, surgical, OB anesthesia, peds anesthesia, respiratory, you name it, they're in the OR. And we could only do this at a large quaternary center like ours. And we're really excited to be able to offer this to a select group of patients. Lastly, in the last couple of minutes, I want to spend on spina bifida, where we're seeing a lot more referrals now. Spina bifida is still quite common in the US. About 1,500 babies are born with spina bifida despite folic acid supplementation and other things. And we diagnose these both by ultrasound or via second trimester screening. You can see here there's a dimple in the lower spine. In this particular fetus has a cystic mass. Sometimes they have this sort of cystic covering, sometimes they don't. And at Packard, this is really a multidisciplinary endeavor with our radiology colleagues, our neurology, neurosurgery, neonatology, MFM, of course, and many others. Really the important thing when we have a diagnosis of spina bifida, we want to determine whether the lesion, which you can see down here, is associated with something called a Chiari-2 malformation. A Chiari-2 malformation is when, because the spinal cord is herniating, it essentially pulls back the back of the brain, and the cerebellum and the posterior brain is herniated into the base of the skull, and that prevents the normal circulation of fluid that happens in the brain. And so babies are at risk for hydrocephalus or high pressure within the brain, and we know that that can be a very morbid condition in the neonatal period. And babies that have spina bifida have two issues. The first relates to the fact that these nerve endings are now exposed to the amniotic cavity, and that can inhibit the leg function and bladder and bowel, because these are the nerves that affect those organs. And secondly, it can affect the hydrocephalus or extra fluid in the brain, and that can lead to a need for something called a ventriculoperitoneal shunt. And so there's a two-hit hypothesis where one is the defect, and two, this ongoing caustic sort of degradation of the nerve endings. And we spend a lot of time trying to figure out where the lesion is. And again, shout out to our sonographers and radiology colleagues who are very good at doing this. And depending on the level of the lesion, we can prognosticate to what effect ambulation will be affected. A very, very long road. We have, I should mention, a long-term sort of program, spina bifida program, where women and families that are referred to our spina bifida program can stay in the Packard system for years, and they can actually go back to their local communities after delivery and come back for ongoing multidisciplinary evaluation by our pediatric neurosurgeons and urology colleagues and many other services. But essentially, from a prenatal standpoint, the thing that we want to try to prevent is this degradation of the nerves and this need for the ventriculoperitoneal shunt. This is what a postnatal repair looks like. This is a fetus that a neonate on day 1 to 2 of life. These are what these lesions look like then. And this is our group, actually, not ours, but the neurosurgeons performing these repairs post day. And when you do in utero repair under open fetal surgery, as you can imagine, these are very invasive and highly multidisciplinary and complex surgeries where we perform a laparotomy, expose the uterus, expose the fetus, the neurosurgeons perform the repair, and then we have to close the uterus and the abdomen and perform a lot of interventions to make sure that the mom stays pregnant. And this is what it looks like. You can see the uterus open. We achieved hemostasis. The lesion is over here exposed. Our neurosurgeons perform the repair. And this is what the uterus looks like. And we put it back. And these patients spend a lot of time on labor and delivery in an ICU type setting for 1 to 2 days. We couldn't do this without the support of our nursing colleagues on the labor and delivery and antepartum unit. A lot of really, really experienced team members to help make sure that moms are safe, or as safe as possible during these procedures. Again, these are just some of the centers or people that are involved here. a lot of strict inclusion-exclusion criteria. And the benefit is really to improve the need for shunt placement and to improve the likelihood of walking independently. But nothing that's good in life is risk-free, and a lot of complications can happen. And so we're really focused on trying to minimize these complications. And really the next procedure that has come around over the last couple of years is really, can we do these repairs under a fetoscopic approach? Meaning, can we do the same repair, but instead of making the hysterotomy, which is the bane of the complications or most of the complications, can we do it by a fetoscopic approach? And there's new information that suggests that we can. And I'll spend more time, with subsequent lectures, or presentations. But in the interest of time, the initial experience seems to suggest that this can be done. And we are developing a fetoscopic program with buy-in from all the specialists. The standard of care therapy is still open repair, and the preliminary data for fetoscopic surgery looks promising, and we hope to institute this soon. It's not just about what therapy you perform, but the patient experience. One of the things that we developed for that, and actually has garnered interest from other fetal centers around the country and even around the world, is we developed a fetal therapy virtual reality program, both for trainees and, more importantly, for families, to better understand what it is that we're doing and what we're concerned about. And unfortunately, COVID hit, and so we're not able to sort of really delve into this, but hopefully as the caseload improves, these are VR programs, both for spina bifida and TTTS. You can find it on YouTube, and I'm happy to show you this at a later time in other sessions. A lot of germane to this center, of course, is a lot of research, innovation, education, both for clinical outcomes research, both for multi-site trials via this North American Fetal Therapy Network. And we're really, I cannot emphasize this enough, we're so excited by this planned, it's still in the early stages, but we're planning a translational science symposium/retreat with translational scientists from Stanford. It's amazing the kind of talent pool that exists here in terms of people that were interested in bringing into fetal medicine and partnering with in order to advance the science, both in translational models and hopefully in long term to advance the science for moms and families. This is the North American Fetal Therapy Network that we're involved with, including multi-site trials, including NIH studies called the GOOD study and the RAFT trial, a lot of other clinical registries that we're involved with. A shout out to our coordinators. We couldn't do this clinically without them. This is our fetal therapy number. If you are interested or have a case or have a family member or somebody that you know that has anything, we're always here to pick up the phone. This is my cell number. And really thank you. I'm sorry we're running out of time, but literally I left you 1 minute for questions, and I promise that next presentations will spend more time, diving deeper into a single disorder, but I wanted to at least give this oversight so that you get a sense of the depth and breadth of what we're able to offer here, and at least give you a glimpse of our fetal therapy program. And thank you for your attention. All right, that's all I got.
Thank you so much.
Amazing work, Yair.
All right, let me stop sharing and let's see what questions people have. Sorry, let's see. What do we have? Sorry. All right, Susan responding there. I have no Pamphtoxo, Susan hints, the services, spina bifida. Thanks, Juno. Thanks, Leslie. And thanks, Brandon. And okay, you have my email. Happy to chat anytime. And thank you, everyone. Have a great afternoon.
Thank you.
Yeah.
Bye.
See you in October.
Thank you.
Thank you.
Hello, everyone.